Hi, my name's Andy Bell. I'm one of the clinical nurse specialists working for the pain service at Addenbrooke's. We cover both the outpatient and clinic side as well as the inpatient side. My background is I've worked within the pain service here at Addenbrooke's for the last 10 years, and I've recently completed a master's in science in the clinical management of pain. After that excellent introduction from Dr. Abrahams, we now move on to the next part of the presentation. This one is focusing more on the physiology, so the causes and reasons of pain in your body and the changes that happen within your central and peripheral nervous systems. It is a bit heavy, but please bear with us because it's essential to gain this good understanding and grounding in the physiology of pain. So once we work through the changes in your physiology system, we'll talk a bit also about acute pain and chronic pain and the differences. And then also we'll look at understanding why more active self-directed strategies work much better than the passive strategies. So acute pain is an important protective mechanism. Every one of you will have had acute pain at some point, whether it's stubbing your toe or shutting your finger in a drawer. This is an important protective mechanism. Once you've hurt yourself, you move away. So your hand will move away from the drawer if you've hurt there. So there is a protective element to it. Chronic pain does not have that protective element to it. Chronic pain is not helpful in that way. We are yet to understand why people develop chronic pain. What we do know is that it happens after about 3 to 6 months. You will often hear, this should be better. I'm sure you've heard that from a lot of people, and unfortunately, this carries on. It lasts beyond how long people expect pain to normally last. It is unpleasant, but there is no protective element to it. So now we know that chronic pain is real and it's happening. You are not alone. You're one of the 20 to 30% of patients in the country that have chronic pain. We need to understand a little bit about why the acute pain, that's a physiological warning sign that we all have, changes to chronic pain. Now, what we know is that one of the main factors is what we call sensitization of your pain system. This means that repeated input into that pain system causes the threshold at which those nerves to fire to lower. So we'll explain that in more detail as we move on through the slide, so please don't worry about the big physiological terms. There's reduction in the spinal cord gating. Again, this is something that we'll talk about in more detail as we go on. We have increased signals from the peripheral nerves. We have central sensitization, and I know we've already mentioned sensitization. I make no apologies for mentioning it again. This is one of the most important things that we will talk about on the day, and whenever you see anybody from the pain service, we will normally mention central sensitization. Again, we cover this as the slides go on. So one of the questions we're often asked is, can chronic pain be cured? And unfortunately, as yet, there is no fix, there is no cure. This is a very difficult message to hear. Many of you will have had pain for many years and will be hoping for something that will take the pain away. What we will do as the presentations go on is give you some self-management strategies that will enable you to take some control back, to get some control of the pain. While we can't promise to cure your pain, what we can do is allow you to manage the pain better. So rather than the pain managing you, you can manage the pain. What we know is the most effective strategies rely on some retraining both of your brain and peripheral and central nervous pathways, and also your musculature. The peripheral nerves, the spinal cord and the brain are all together commonly and collectively known as the central nervous system. There are trillions of messages sent from the peripheral nerves to the central system every day. It's your body's job to decide which of these messages are sufficiently strong enough to warrant you doing something about them. Within the spinal cord, and specifically the dorsal root ganglion, there's a filter that would normally block some of these messages and let some of those through. Within chronic pain, what happens is that this filter stops working and can actually sometimes do the reverse and propagate or make that message more loud and more intense. Normally, any sort of physical stimuli can cause activation of a receptor in the peripheries, and this will send a message to the central system. Within pain, this message is normally transferred via a very specific nerve called a nociceptor that has a very high threshold. This means that not everything is painful. Otherwise, as we're walking around and brushing into things and touching things, we would be constantly inundated with painful signals. Unfortunately, as we've just mentioned, in chronic pain, sometimes this firing system stops working and can actually propagate the message. The point at which these nociceptors usually fire their message is called the threshold, and this is why we've mentioned threshold before, and we will continue to mention it. Within chronic pain, the threshold for firing is lower. So for a nociceptor or a pain nerve to fire, there needs to be a stimulus. That stimulus is often caused by tissue damage in the periphery, which releases a chemical soup. Some pain nerves have what we call a synapse, which is a join between the nerves, and this can be either in the peripheral part of the system or the central part of the system where that dorsal root ganglion is. The synapses are important because they're the point at which we can modulate or change that signal. So now we're going to move on to talk a little bit more about that pain gate, so the system that facilitates or stops transmission of the pain message. This gate can be opened or closed depending on a multitude of different factors. If the gate is closed, the pain message is reduced and the stimulus and the sensation that gets through is therefore reduced also. If the gate is open, then the signal is free to flow through and the pain is felt more readily. There are many things that we know that can open or close the gate, including messages that are transferred from the periphery to the central area, or also from the brain back down the spinal pathway. Both of these are either known as ascending or descending. So the ascending message is from the periphery up to the brain. The brain then reads and detects this message and sends a descending message down. So both of these systems, the ascending and descending system, can be adjusted. And what often happens in chronic pain and in central sensitization in particular is the ascending system. So the system that's taking the message up towards the brain becomes too loud, and the descending message, so the message from the brain coming back down, is too quiet. And what we need to do is reverse this trend. So although in chronic pain there is no ongoing tissue damage, what we know is that the chemicals that are released in the central system mimic and are very similar to those that are released when there is tissue damage and cause similar sensations and a similar upregulation of the pain system. So these chemicals affect the ascending pathway. These are the ones that make that message too loud. There are also chemicals that are released that affect the descending system. This is our own inbuilt way of turning down that pain message. These are released when we are exercised, when we're relaxed, when we practice active relaxation or distraction. These are all inbuilt chemicals that we can boost in this way. So the brain plays a vital role in the management of pain. What we know is there are very complex spinal and brain pathways that involve both sensation, memory, and perception of pain. That's not to say that your pain is not real or in your mind, but it does mean that you have some control over the way that pain is felt and what meaning you attach to it. What we know and what we understand is that everybody has a mental map of their body. So if you close your eyes, you're able to point to where your knee is or where your hip is or your nose. This is because your body understands where those regions are. Areas that are more highly sensitive have more input into that area. As we can see from the picture here, it would normally be those areas that are involved in sensing and sensation. So your hands, your lips, your tongue are highly innervated. When you have chronic pain, the area that you have the pain in also becomes highly innervated, and that area would be increased on this picture. So for example, if it was knee pain, the size of your knee would be increased. If it was back pain, the size of your back would be increased. And what this is highlighting is that the area of pain becomes hypersensitive, and the brain understands this because it's getting repeated input from that area and becomes lit up like a beacon. So that area of the brain becomes very sensitive. This altered sensation alters your mental map. It alters the way that you perceive sensation from that area, and it affects the way that you can deliver that descending message, the message that normally would turn the pain down. A good example of this is something like phantom pain, where although the limb is not present anymore, actually the pain is still felt and still felt just as real, and sometimes can be felt worse even though the limb has gone. This is because the central and brain part of that system are still there and are still firing that message and need to be aided to calm down. So now that we know that there is a rearrangement and a highlighting of these areas within your cerebral cortex, within your brain, a lot of the strategies that we'll talk about are aimed to try and realign this system to make it more normal again. So our brain looks at the meaning of a situation. Now if you look at the picture, take a few seconds. Now some of you will have seen white chess pieces, and some of you may have seen black hooded figures leaning towards each other. What this highlights is that even a simple picture on your screen can give different outcomes to different people. So if we think about the complexity of your pain system and the messages that you are receiving, it just again highlights how very individual and difficult pain management can be. Unfortunately, what we know is that the brain, and particularly the subconscious part of your brain, cannot distinguish between what is an acute pain and what is a chronic pain. As we mentioned earlier, acute pain is an important protective mechanism. It's essential to keep us safe, whereas chronic pain has no physiological benefit that we know of. Therefore, not being able to distinguish between these two means that you understandably often associate pain with damage, even if there is no ongoing damage. This muscle spasm and tightening, unfortunately within chronic pain, will often propagate or worsen the pain, and this is a very important part of your pain management. Next is a short video presented by Professor Lorimer Moseley, who's done a lot of work in the clinical management of pain and investigating pain and pain management in humans.
Let me tell you a story. I just want to take that off the screen for the moment. I want to tell you a story that will explain to you the first 3 years of the neurobiology of pain that you would study at university. 8 years ago, I was walking in the bush. I had a sarong on. Very cool. This is what happened. Did you see that? Hang on. This is what happened. Biologically, I'm going to tell you what happened just then. Something touched the outside of my left leg in the skin. That activates receptors on the end of big, fat, myelinated, fast-conducting nerve fibres. And they stream straight up my leg, straight into my spinal cord, up to this part of my brain. And they say, you've just been touched on the outside of your left leg in the skin. Meanwhile, whatever it was is sufficiently intense to activate free nerve endings. We call them nociceptors. They're thin, unmyelinated, slow-conducting Lada Neva. Someone knows what a Lada Neva is. Nerve fibres. And that message travels up to my spinal cord, and it gets to my spinal cord, and that's as far as it goes. And it says to a fresh neuron in my spinal cord, you've just been, something dangerous has happened on the outside of your left leg in the skin, mate. And the spinal nociceptor takes that message up to the thalamus, which sits in there somewhere, and says, there's danger on the outside of your left leg in the skin, mate. Now the brain has to evaluate how dangerous this really is. So it looks at everything. And the way that I make sense of this, of what happened to me, is the brain thought, frontal lobe, have we been anywhere like this before? Hang on, I'll just ask the posterior parietal cortex. Have we been in this environment before? Yes, we have. Has it happened at this stage of the gait cycle? Yes, it has. Is it coming from the same location? Yes, it is. What is it? Well, your whole life growing up, you used to scratch your legs on twigs. This is not dangerous. I'm going to give you, the organism, just something so you can kick off the twig and continue on your merry way. And that's what happened for me. I can't show you now, but I took off my sarong, got in the river, got out of the river, and that's the last thing I remember, having been bitten by an eastern brown snake. Survivor. Thank you very much. Now, for some reason, the eastern brown snake works by poisoning you, clearly, and one of the things that it does is activates nerve fibres. So actually, my brain would have got all these messages saying, danger, 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 danger. And in its wisdom, it said, no, 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 no. 6 months later, I'm walking in the bush with a boring talker. You know what a boring talker is? Those people, it doesn't matter what they say, it's boring. That's irrelevant, but we'll call her Naomi, because that is her name. Anyway, this is what happened, right? Oh, wah! And I am in agony. I have got a white hot poke of pain screaming up my leg. I'll tell you biologically what's happened. Something touched the outside of my left leg in the skin. That activates big, fat, myelinated nerve fibres, which send a message up to here. Just me touching the outside of your left leg in the skin. It's sufficiently intense to activate these free nerve endings, danger receptors. Take the message to my spinal cord. Just been, something dangerous has happened on the outside of your left leg in the skin. Yes. Well done. You weren't planted. that goes to the thalamus and says the same thing. Something dangerous has just happened on the outside of your left leg in the skin. So the brain says, thanks very much, thalamus. Kids all right? Good. Anyway, frontal cortex, anything to tell me about this? Hang on, I'll ask the posterior parietal cortex. Where are we? We're walking in the bush. Oh. You're a bit mate happy. This stage of the gait cycle, where's it coming from? Have we been here before? Oh, yes, we have. Last time we were here, you almost died. I'm going to make this hurt so much that you can do nothing else. And I was in absolute agony.
It's really worthwhile just taking a moment to think about that, because that attaching of meaning to pain is vital in understanding why chronic pain can be propagated and maintained, and how sometimes it's very difficult to control. As we've said before, unlike acute pain, chronic pain has no useful purpose that we know of at the moment. It does not function as a warning. There is often no further ongoing damage. It has no benefits that we can detect. It is purely unpleasant. So now we're just going to talk a little bit more about how the nervous system changes in chronic pain. What we know is that more receptors are expressed, so there are more pain receptors, and more of these pain receptors become activated. That threshold, so the point at which they fire, becomes much lower. So as we've said before, stimulus that would not normally cause the pain nerves or the pain system to fire, cause the pain system to fire. Things that would normally be painful and cause that system to work become more painful and last for longer. So because of this ongoing sensation, the body starts to think that the pain message is a normal message, and it does what it would normally do to any other message that it's getting repeatedly, which is to turn that message up, because it feels that you need to know about that message. If it's there all the time, it must be important, you need to know about it. To this end, the central system continues to become sensitized. That spinal gating system stops doing its job. Again, part of that is because it keeps receiving these messages, it becomes slightly overwhelmed, cannot filter all of them out, so more of those messages get through. These changes to the nervous system are called central sensitization, and I make no apologies for mentioning this again. I'm sure you'll have noticed it's a theme that's running throughout this presentation. It's one of the most important things that you can take away. This sensitivity is almost a self-fulfilling prophecy. The more sensitized you get, the more the body thinks that you need to know about these signals, the more sensitive you get. Although pain is a very subjective and individual experience, there have been some studies that have highlighted the physiological changes that can take place in chronic pain. So one piece of research showed that within a normal knee you would receive roughly 4,000 signals every 30 seconds. However, within chronic pain this figure is changed. How do you think the figure changed? In fact, there were nearly 40,000 signals generated every 30 seconds, so that's nearly a tenfold increase in the signals from that area. So sometimes the nervous system can be so sensitized that even just thinking about pain can make the pain worse. And there's a chemical reason for this as well. Sometimes, as we've mentioned, when we're stressed or anxious, we release some of those sensitizing chemicals that we mentioned earlier. Conversely, when we're more relaxed, we release some of the descending chemicals that calm down the pain sensation and the pain message. So what we know, as from the presentations and from the video that you've watched by Professor Lorimer Moseley, is that there are very complex pathways within your pain system that involve several areas of your brain, including memory and perception. So the brain uses this system and the signals it receives to interpret its environment and attach meaning to those signals. Things like past experience, anxiety, worries and stress. And this leads us on to why and how things such as the ideas involved in cognitive behavioural therapy can be so effective in managing chronic pain. So thank you for listening and watching that presentation. Hopefully that will have given you a good understanding and grounding in the physiology of pain and how acute and chronic pain are different, and hopefully, although we've mentioned it plenty, you will not forget central sensitization, as this is one of the most important parts, and the impact that this has on the way you perceive pain and the meaning that can be attached to that pain. What this does is underpin the next few presentations and hopefully give you an understanding into why these can be so effective in the management of your pain.
Everyone agrees that pain is a universal human experience. We now know that pain is 100% of the time produced by the brain. This includes all pain, no matter how it feels, sharp, dull, strong or mild, and no matter how long you've had it. You might have had it for a few weeks or months. This is called acute pain, and it's common with tissue damage, say from a back injury or ankle sprain. And generally, you'll be encouraged to stay active and gradually get back to doing all your normal things, including work. Or you might have had it for 3 months or more, and this pain is generally called persistent or chronic, because in this type of pain, tissue damage is not the main issue. What's less clear, though, is when you're told you have chronic pain, is knowing what's best to do about it. Well, in Australia, chronic pain is a really big problem. In fact, 1 in 5 people have it. Having a brain that keeps on producing pain, even after the body tissues are restored and out of danger, is no fun. Some people say it still feels like they must have something wrong. But that's just it. Once anything dangerous is ruled out, health professionals can explain that most things in the body are healed as well as they can be by 3 to 6 months. So ongoing pain being produced by the brain is less about structural changes in the body and more about the sensitivity of the nervous system. In other words, it's more complex. So to try and figure out what's going on, you need to retrain the brain and nervous system. To do this, it's helpful to look at all the things that affect the nervous system and may be contributing to your individual pain experience. What can help is to look at persistent pain from a broad perspective, and by using a structured approach and a plan, it's less likely that anything important will be missed. Let's start with the medical side. Firstly, taking medication can help, but only to a limited extent. It is the more active approaches that are necessary to retrain the brain. So using medications to get going is okay, and then mostly they can be tapered and ceased. Some people also think surgery might be the answer, but when it comes to a complex problem like chronic pain, surgery may not be helpful. So if you're thinking of surgery, it's best to get a second opinion and remember to consider all the things. Next, it is helpful to consider how your thoughts and emotions are affecting your nervous system. Pain really impacts on people's lives, and this can have a big effect on your mood and stress levels. All those thoughts and beliefs are brain impulses too, but you can learn ways to reduce stress and wind down the nervous system. This helps with emotional well-being and can reduce pain as well. The third area to consider is the role of diet and lifestyle. Now, it turns out that our modern lifestyle might not be so good for us. In fact, what we eat and how we live may really be contributing to a sensitized nervous system. Looking at all the things like smoking, nutrition, alcohol, and activity levels, and seeing if there are any issues is a good beginning, and these things can go on your plan. Then there's often enormous value in exploring the deeper meaning of pain and the surrounding personal story, by stepping back and looking at all the things that were happening around the time the pain developed. Many people with pain can make useful links between a worrying period of life and a worsening pain picture. For many, recognizing deeper emotions can be part of the healing process. Last, but by no means least, is physical activity and function. From the brain's perspective, getting moving at comfortable levels without fear, and where the brain does not protect by pain, is best, and you'll gradually restore your body's tissues. So, to sum up pain, it comes from the brain and it can be retrained, and when looked at from a whole person or broad perspective, gives you a lot of opportunities to begin. So get a helping hand if you need it, set a goal, and begin.